The controversial use of Suboxone, treating opiate addiction with an opiate agonist. There are many treatments available for those who have substance abuse disorders, but there are none so controversial as treating an opiate dependence with another opiate. The Federal Drug Abuse Treatment Act of 2000 made it possible for physicians with specialized training to prescribe buprenorphine. Suboxone or Subutex are the brand names. There have been many studies done to prove the efficacy of this treatment, and many see it as a miracle for those who were once unwilling to abstain from opiates. However, others see it as simply substituting one addiction for another. So what is Suboxone? Suboxone is a combination of two drugs, buprenorphine and naltrexone. Buprenorphine is a partial opioid agonist, and naltrexone is an opioid receptor antagonist. The combination of these two drugs creates a powerful yet controversial medically assisted treatment for opiate addiction. This follows the harm reduction model of treatment. The main controversy of this drug is the fact that one drug, which can be very addictive itself, is taking the place of another. Proponents claim that the benefits of Suboxone far outweigh the risks. Opponents believe that the abuse potential and diversion of the drug are risks that our society cannot afford. An overview of the pros of Suboxone. The main benefit of taking Suboxone is the reduction of the severity of withdrawal symptoms from heroin and other opiates. Suboxone also controls cravings and blocks opiates. It is seen as a much safer alternative to the use of methadone, which has been predominantly medically assisted treatment prior to buprenorphine, because of the ceiling effect. While there are associated risks, proponents believe that Suboxone is the lesser of two evils, and the success rate after taking Suboxone for 1 year is proof that it is a viable option. The reduction of symptoms from withdrawing is probably the number one benefit from Suboxone. People who are addicted to opiates are often unwilling and unable to stop due to the negative effect associated with opiates. Proponents claim that substituting buprenorphine for other opiates allows those who are addicted to a substance the ability to avoid the negative withdrawal symptoms without being physiologically impaired. This also helps in the retention rates in treatment centers. And once the treatment is over, withdrawal from Suboxone is very minimal in comparison to that of opiates. Suboxone also controls the craving and blocks opiates. It reduces opioid cravings by increasing the amount of dopamine and regulating the number of neurons in the mesolimbic pathway. Since it reduces one's cravings, it is seen as a good maintenance therapy. In addition, according to Wesson and Smith, buprenorphine blocks other opiate drugs like heroin from reaching the receptor, which prevents the effects of that opiate on the body. For instance, if a person who is using Suboxone decides to use heroin, he or she will not get the high that is normally expected. This aids in the prevention of relapse. The next is the ceiling effect. One of the reasons opiate addiction can be fatal is the increased amounts that affect the respiratory system. As a person continues to use opiates, their tolerance grows, and there is a need for increased dosages to achieve the same effect. According to Nessman, Suboxone is considered a safe alternative because as dosages increase, the drug reaches a ceiling and then begins to have an antagonistic effect. Buprenorphine's ceiling effect on respiratory depression translates into less concern for overdose deaths. Then there is the success rate. While the U.S. is still waiting for the results of this drug's ability to adequately treat addiction, France has reported an 80% decrease in fatal overdoses from opiates since their country initiated the use of Suboxone, which was 10 years prior to FDA approval here in the United States. According to Stuckart, some studies from the last few years have shown significant improvements resulting from maintained sobriety with the use of Suboxone. After a 1-year period, approximately 40 to 60% of those on the program have remained sober. In addition, reports show that there is a higher retention rate in treatment facilities due to this decreased effects from withdrawal. It has also decreased the number of fatalities. Fatalities linked to the drug are actually really rare because it does not suppress a person's breathing. The cons of Suboxone use. In addition, there is evidence to suggest that, although not as potent, Suboxone carries a high risk to abuse and addiction. On the other hand, opponents claim that one is not working a real program of recovery if they are substituting opiates with buprenorphine. A person is still considered to be addicted or dependent on a substance, and for this reason, when used as a maintenance therapy, many view this treatment method as the lesser of two evils rather than true abstinence. Critics say that administration of buprenorphine is not sufficient on its own because it only treats the physical symptoms and not the underlying issues or behaviors associated with drug use. In addition, there is evidence to suggest that although not as potent, buprenorphine can also be addictive and toxic. Lastly, while this substitute for opiates is deemed successful for the treatment of withdrawal symptoms, it falls short when it comes to relapse prevention. Now we're going to talk about each one of these a little bit more in detail. Addiction potential. There are many that subscribe to the belief that one is not considered to be clean or sober if they are using a medication to help overcome another one. Many opponents see this as a mere transfer of addictions. Since Suboxone is considered a narcotic and affects the reward center, the brain never gets a chance to heal. The continual use of this drug will also cause a dysregulation of dopamine in the brain. Although not as potent as other opiates, such as heroin, Suboxone still carries a high risk for abuse and addiction itself. Then there are the health warnings. According to the SAMHSA, buprenorphine, the key ingredient in Suboxone, was involved in 10 times as many emergency room visits than 10 years prior. That's 30,000 that were in 2015 versus only 3,000 that were in 2005. Children are also ingesting Suboxone accidentally due to improper safeguards of the drug by the parents. In fact, according to the CDC, Suboxone was the cause of 9.5% of all drug-ingested hospital visits from children less than 6 years old in 2014. Other health risks occur when Suboxone is used in combination with alcohol or other drugs. This can cause hepatitis, coma, and even death. Lastly, although Suboxone has a ceiling effect, it is still possible to die from an overdose. This is especially true for those who are using this drug recreationally. Another con is the fact that diversion to illicit drug use is predominant. Suboxone has been increasing popularity and available in the last few years. Despite the fact that specially trained physicians are the only ones allowed to prescribe this medication, Suboxone has found its way into the world of illicit drug use. Addicts will often use this drug in between their fixes of heroin so that they do not have to face the withdrawal symptoms. In a survey of individuals presenting for prescription opioid abuse treatment in the United States, approximately 6% of participants reported injecting buprenorphine to get high, but percentages are much higher in other countries. It also does not prevent relapse. Although Suboxone has been shown to be clinically effective in helping to control cravings, the evidence does not support relapse prevention. The reason for this is that it does not activate the part of the brain associated with relapse. In fact, some studies suggest that the chronic blockade of the opioid receptor will eventually increase the likelihood that a person will relapse upon abstaining from the drug. In summary, proponents have valid claims in the effectiveness of Suboxone. It is seen as many as a miracle drug because it enables addicts to stop using heroin without having to undergo all the terrible withdrawal symptoms. This aids in the retention of patients in a treatment facility where they can focus on their recovery. Although this drug is an opiate itself, the combination of ingredients allows for the feeling of well-being rather than the feeling of being high. However, critics of the drug claim that despite its effectiveness, one drug is just being substituted for another, and another addiction is in danger of being developed. In addition, Suboxone does not help a person's brain heal from the dopaminergic effects caused by chronic drug use. Despite the ongoing controversy, Suboxone is starting to be accepted by more practitioners and treatment centers. My critique of this is rather interesting because when I first started to do this research, I was on the side of the critics. I didn't agree with Suboxone. but after learning a lot about it, I have really changed my mind. While we wait for other possible solutions to the opioid crisis, I feel that the use of Suboxone is an acceptable form of short-term treatment. Although the drug carries its own risk of addiction and dependence, I feel that it is the lesser of two evils. There are those who would not try to stop taking heroin for fear of the withdrawal symptoms. This provides a safe and effective way to step down and start on a path to recovery. The use of Suboxone should be closely monitored and combined with counseling and other recovery treatment options with a goal and a plan for complete abstinence. I believe that researchers should continue to push for safeguards to make sure the product is safe as possible and find ways to deter abuse as well as diversion.